So this is LU7 Preceptorial, July 28th. So we have 6 mentees. Okay. And then the learning objectives will be the following. Okay, just for a reminder, I know you're familiar with all these learning objectives, but as faculty, I have to repeat it. No? So the mentees provide the details, the clinical data clearly, concisely, and relevant information, provide good history and present complete physical examination findings as one would proceed in the bedside preceptorial, and also the relevant physical exam findings, give the differential diagnosis, and explain how the group arrived at the primary working impression. Okay, so you must do it efficiently. And then explain the pathophysiology of the disease at hand and may include theoretical data or possible existing epidemiology of it. So to save time, we will just focus on the relevant items, the data. Then provide options for additional diagnostic maneuvers or studies. Then provide a surgical plan or even a medical plan if the patient does not need any operation or other treatment options. And then present a journal appraisal of a relevant clinical question regarding the management of the patient. Okay, so these were the learning objectives that I got from your curriculum, from your instructional design. So is everything clear? Can we agree on this?
Yes, sir.
Okay. And then as to the how you'll be evaluated, I was given also the list. Okay, so history, physical exam, differential diagnostic treatment plan, relevant journal, psychosocial concern, question and answers. No? So most likely this will be on participation, and then communication skills, and then your presentation. Okay, total of 45 points. Okay. So basically, it will focus on your history, physical examination, working diagnosis, plan of the diagnostics, the treatment, and then the prognosis post-op complications if this is a surgical case. Okay, clear?
Yes, sir.
So criteria of journal appraisal, I hope you have gotten a copy of this as a guide for you. Okay. So research question based on the clinical problems that you identified. Okay, describe the how the article was sought. Okay, summary of the journal and journal appraisal. Okay. And then for the grading, I will do individual grading rather than group grading. So, but the difference is probably will come out during the active participation part. Okay. So you'll be answering some of my questions, and then you can ask questions to me. Okay, so just to show that you are actively participating. Okay. Okay. So then, okay, on this class, you're going to evaluate me through the following: explain the objectives, expectations, and various requirements, which I've done. Encourage students to think critically, communicate clearly, answer questions, then understand the complex ideas, engage in use helpful learning exercises and activities, relate the subject matter to issues development in the discipline and or the real life concern, encourages the students to participate in the discussions, make himself available for consultations. I don't know how I'm going to do this, probably through online. Encourages students to express their ideas and viewpoints, communicates, interacts with students in a positive way, shows respect for students' diversity and individual differences, make full use of the required learning hours, required hours for learning. I hope we can finish it within 2 hours. Okay. Provide fair and timely feedback on student performance, use clear criteria to evaluate students' performance, which we have presented. Okay, so then others will be in relation to your learning experience in this class. What does your teacher do that you find very helpful and effective? How do you think can the teaching this class be improved, enhance your learning experience? How can the teacher utilize technology more efficiently to enhance your learning? Okay, this is in the time of this Zoom pandemic. Okay, but we're still using Zoom online. Okay. Okay, everything clear? So
yes.
So a short introduction, orientation. So we will, I suppose you have presented a PowerPoint, right? Okay. So
Yes, sir.
to save time, you just present it. I'll just jot down my questions and comments. Then we will just uh, what do you call that? We will just interact later on after your presentation. No? Okay?
Okay, sir.
Go ahead, sige. You have can you have the sharing? Okay. You can share.
Yes, sir.
Okay.
Oh, sorry. Wrong one. Sorry. Uh, Here. Okay, so for today, we'll present a breast cancer case. Again, we're LU7. So we're gonna have a case presentation on a patient who presented with a left breast mass. So to start, we're gonna have the history and PE of the patient. So our patient is IY, a 39-year-old female who is an office worker from Manila. So she had a 1-year history of a solid mass in the left upper breast in the 10 o'clock position, with nipple inversion, but no other skin changes such as redness, erythema, or podiorange, and nipple discharge. And then 3 months after, around 9 months prior to this admission, the persistence of the mass prompted consult at her local hospital, where they ordered an ultrasound and a mammogram, which had suspicious findings, Byron's 5 finding in the ultrasound, which prompted the local hospital to refer her to a higher institution, which at that point was PGH. And when she arrived at PGH after that referral, more workup was requested, which we'll talk about more in our diagnostics part. So for the relevant ancillary history, she has no known comorbidities. She's had no previous surgery or radiotherapy. She's not on any maintenance medications, and she has no known allergies. For her family medical history, she has two aunts from her father's side. Her father's siblings also had breast cancer when they were around 60 to 70 years old. And she also has another cousin from her father's side who has a breast mass but is pending diagnosis. She has no vices, does not smoke, does not drink alcohol, and denied illicit drug use. And finally, for her OB history, she's a G2P2 2002. She had her first menses at 14 years old on regular intervals, around 5 days in duration, around 3 non-fully soaked pads, and no dysmenorrhea. She has no history of contraceptive use, and she was 32 years old when she had her first child.
On physical examination of the patient, the rest of the physical exam was unremarkable. For the systemic physical exam, next slide, please. However, on physical examination of the breast, we noted a 4 by 5 centimeter solid, hard, non-tender mobile mass at the upper inner quadrant of the left breast, approximately at the 10 o'clock position, 2 centimeter from the nipple, with associated nipple retraction, as you can see at the images flashed in the screen. There are also no overlying skin changes, discharge, and as highlighted in the two pictures on the left and at the center, we were also able to note a 1 by 1 centimeter hard lymph node at the left anterior axillary line.
So next, let us discuss the clinical diagnosis. So first, we should identify data from the database which can serve as cues for our clinical diagnosis. So first, the fact that our patient is a 39-year-old female. I will explain these informations further on later. So next, we should also take note of the 1-year history of a solid, mobile, non-tender 3 centimeter mass, and also the subjective complaint of the nipple inversion. Next, based on the physical exam, we should take note of the 4 by 5 centimeter solid, hard, movable mass. Also consistent with the history, we also noticed nipple inversion based on the PE. And also we were able to palpate a 1 by 1 centimeter single hard lymph node in the anterior axillary line. It is also important to take note of the patient's family history of having breast cancer in 2 paternal aunts who were diagnosed around 70 years old, and also our patient's OB history of late parity. Next slide, please. So based on this information, our primary clinical diagnosis is breast cancer, and our secondary clinical diagnosis is fibroadenoma. I will explain this further in the next slide. So we are considering breast cancer because of these reasons, no? First, because breast cancer has an increased prevalence in women. So breast cancer occurs actually 100 times more frequently in women than in men. And so the fact that our patient is a female points more towards breast cancer. Next, our patient's family history of breast cancer, no, not only 1 but 2 paternal aunts had breast cancer in the past. So the risk of breast cancer is increased almost 2-fold if a woman has 1 affected first-degree relative, and it is increased 3-fold if she has 2 affected first-degree relatives. So the fact that she has 2 really increases her risk for breast cancer. Again, like what I mentioned a while ago, our patient's late parity also increases her risk of breast cancer. So late parity is described as having a first pregnancy or a first child after the age of 30 years old. So our patient had her first child at the age of 32 years old. So this makes her have late parity, no? So this is due to breast cancers. 8 out of 10 breast cancers are hormone receptor positive. So these cancers need hormones such as estrogen, progesterone to grow. So the excess exposure to estrogen raises the cancer risk. Next, also the fact that our patient has nipple inversion also points more towards a breast cancer, because nipple inversion points more to a possible tumor attacking the milk ducts behind the nipple, which causes the skin to pull inward. And it can also be due to the cancer cells directly affecting the nipple itself to cause the skin changes. And lastly, the fact that our patient already has axillary lymph node involvement also points more towards cancer, because as you all know, diba, cancer cells activate our immune systems, which cause the proliferation of lymphocytes and thus the swelling of the lymph nodes. Here are some facts naman that make breast cancer a little bit less likely in our patient, but again, it doesn't completely rule out breast cancer. The fact that our patient is relatively young, she is 39 years old, and as we know, breast cancer is common towards more of mga 65 to 74 years old. The median age of diagnosis is around 63 years old. But it is also notable that breast cancer is the most common type of cancer found among young adults aged 15 to 39. Next, the fact that the mass that our patient has is movable points less likely to a breast cancer, because breast cancer lesions are more fixed, diba? But again, these characteristics don't completely rule out breast cancer. And lastly, the fact that our patient does not present with any constitutional symptoms such as unintentional weight loss, night sweats, or fever make it less likely. Now, our secondary clinical diagnosis, we're also considering fibroadenoma, primarily because of the characteristic of our patient's lesion, the fact that it is firm and it's movable, painless, unilateral, those characteristics, no? And also the fact that our patient is relatively young. Fibroadenomas are the most common benign tumors in the breast, and they are quite common at younger ages, around 30s and 40s. So we consider this in our patient. But this diagnosis is less likely because of the fact that our patient has nipple inversion and axillary node involvement, which are yun nga pointing more to malignant and more invasive disease. Next slide, please.
Okay, now moving on to the diagnostics of our patient. So just to reiterate, our primary clinical diagnosis is breast cancer, and our secondary clinical diagnosis is fibroadenoma. So next slide, please. Okay, so now we have to decide whether we need a paraclinical diagnostic procedure or not. And our decision is yes, further diagnostic workup is needed, especially since we are at the branch pointed management, because differentiating between breast cancer versus fibroadenoma is management changing, as we can see here in the table. So with our primary diagnosis of breast cancer, we are around 70% certain, and the treatment modality would have been lumpectomy or mastectomy, chemotherapy, radiotherapy, or hormone therapy, depending on the staging histology and immunohistochemistry results. And then we are around 30% certain of our secondary clinical diagnosis of fibroadenoma. And the management, as we can see, it will change because usually we just observe or monitor these types of lesions, or we could also decide to excise the lesion surgically. Okay, next slide. So yes, just to reiterate, further paraclinical diagnostics are needed to differentiate a malignant breast lesion from a benign fibroadenoma. In particular, so remember there's a triple assessment of the breast mass. So we assess the patient clinically through history and physical exam, which has been done. We also ask for additional imaging, particularly breast ultrasound and mammography. And the third, we ask for biopsy. So in particular, biopsy is warranted, especially since by history and imaging, the lesion is suggestive of malignancy. So since a malignancy can only be confirmed with histologic diagnosis, the next step for our patient in the workup of our patient is tissue diagnosis through biopsy. So next slide, please. So there are several methods that a biopsy can be obtained from a breast mass. And first, and the method that we will prioritize is core needle biopsy. So some of the benefits of core needle biopsy is that it's better than fine needle aspiration at histologic evaluation because it can provide information on the tissue architecture of the lesion. And it can also obtain tissue specimen for immunohistochemistry staining, particularly for ERPR and HER2. So the risk, however, of core needle biopsy or CNB is that it's more invasive and painful than FNAB. And the cost, according to the case rates of PhilHealth, is around 3,640. And for the availability, it's available in most hospitals. So next, for comparison, with the other option is fine needle aspiration biopsy or FNAB, which is quicker and less painful and less invasive compared to core needle biopsy. However, no tissue architecture is seen, so thus it fails to detect some of the important diagnostic and prognostic parameters. So the cost is similar to CNB. However, overall, it's a very simple and quick and economical method and thus it's more widely available even in resource limited settings. Okay, next slide, please. The third method of obtaining a biopsy is surgically. So through an excisional biopsy, the benefit is we remove the tumor or the lesion. However, this is the most invasive method out of all the three, and it only removes the lesion. So there's the risk of inadequate margins in the case, and if ever this lesion is invasive cancer. And it also generates scar tissue inside breast tissue that may show up on future imaging. So the cost is also the most expensive at around 5,560 according to the PhilHealth case rates, and it's available only in hospitals with operating room capacities. Okay, so next slide. So our chosen paraclinical procedure is the core needle biopsy. So just to briefly describe how it is done. So of course, antisepsis of the exposed area is first performed. After that, we localize the lesion on ultrasound, and local anesthesia is administered to the biopsy site. So a small skin incision is made with a scalpel to prevent unnecessary trauma upon introducing the core needle. So there's a device that has the core needle, and while maintaining visualization of the lesion on the ultrasound and as well as the needle tip, we can advance the core needle through the incision site, and the device is fired once the needle is in position as seen on the ultrasound. So several samples are retrieved and preserved in formalin to aid in tissue diagnosis. So next slide, please. So the histological findings that would suggest our primary diagnosis of breast cancer would be a malignant proliferation of neoplastic cells that invade the duct wall into the stroma. So this is suggestive. Or here we can see in this photo here is the pathology of an invasive breast cancer on the microscope, and you can see infiltrative nests of tumor cells that suggest invasive breast cancer. So next, here we present the results of our patient. The core needle biopsy results as well as immunohistochemistry results of our patient. So we can see here that the core needle biopsy revealed a typical infiltrative glandular proliferation compatible with invasive breast carcinoma, not otherwise specified. And meaning our patient has invasive ductal carcinoma. And for the immunohistochemistry, the ER and PR and HER2, ER and PR are positive, and HER2 new was negative on IHC staining. Okay, so next slide, please. And then here we just briefly go through the pre-op workup of our patient. So the CVCU differential was unremarkable, no anemia, no thrombocytopenia, no leukocytosis of any sort. And then the coagulation studies were also normal. PTT and PT were not prolonged. Okay, so next slide, please. And then blood chemistry was also normal kidney function test with a slight elevation of AST, but otherwise normal liver function test, no electrolyte imbalances. Okay, so next slide. And then next slide, please. Urinalysis was also requested for this patient pre-op, and this revealed microscopic hematuria, elevated leukocytes, but otherwise a normal urinalysis. Okay, so next. And the ECG was also showed normal sinus rhythm, no abnormalities of any kind. And the next slide. Here is the clinical radiologic report of the chest X-ray. So there was non-specific apicopleural thickening and thoracic dextroscoliosis, but otherwise it was a normal chest X-ray. Okay, so that's it for the diagnostics.
Okay, so moving on to treatment. So just to restate our primary and secondary diagnosis, our pre-treatment primary diagnosis is breast cancer, while our pre-treatment secondary diagnosis is fibroadenoma. Next slide. So the following are our goals for the treatment of our primary diagnosis of breast cancer. Number 1, to prevent progression of disease. Number 2, prevent morbidity, mortality, and disability during surgery. Number 3, prevent recurrence of cancer. Number 4, ensure patient satisfaction. And number 5, improve quality of life. Next slide. So deciding on our treatment modality, we entertain several non-operative and operative treatment modalities. So starting with the non-operative ones, first we can consider radiotherapy, which is a more targeted therapy with less systemic side effects. And it's usually used as adjuvant therapy after surgery to prevent local recurrence. Some of the side effects of radiotherapy include lymphedema, skin irritation, swelling of the breast, fatigue, and fibrosis. According to the PhilHealth first case rate, it's 3,000 pesos per session. And it's not available in most local hospitals, but available in larger centers such as PGH. Second, we can entertain using chemotherapy. Usually, this is used as neoadjuvant therapy to shrink tumor size before surgery for locally advanced breast cancers, or it may be used as adjuvant therapy to kill residual cancer cells. There are general side effects associated with chemotherapy, including nausea, vomiting, hair loss, fatigue, and anorexia, and those associated with specific agents. For examples, for anthracyclines, including doxorubicin and epirubicin, we see side effects such as cardiomyopathy, congestive heart failure, and leukemia. For taxanes, including paclitaxel and docetaxel, peripheral neuropathy is observed as a side effect. And there are many regimens of chemotherapy available, but here's a sample of an estimated cost of a chemotherapy cycle. So the computed cost was around 6,000 pesos per cycle, and it's available in most hospitals. Next slide. For the last non-operative treatment modality, there's hormonal therapy. So this is also used as adjuvant therapy after surgery, but only for those that are ERPR or hormone receptor positive breast cancer. Uh, it has less severe side effects compared to chemotherapy. Um, the side effects are usually just hot flashes, um, but there's also a risk of thrombosis and muscle and bone pain. Many agents may be used, but as an example, there is tamoxifen, which is 11 pesos per tablet, and letrozole, which is 52 pesos per tablet. And it's available in most hospitals and pharmacies. Next slide.
Okay, so we'll proceed to the operative options for this patient. Since this is a relatively early stage breast cancer, stage 2B, primary management or definitive local treatment can be done by surgery. And we have two options that we can offer to the patient. The first one would be a modified radical mastectomy. It's the standard of care among those with early breast cancer. The survival equivalent is comparable to radical mastectomy. However, it offers less morbidity compared to radical mastectomy. The risks associated with MRM are those associated with general anesthesia as well as those which are particular for for MRM. Most of the time, the risk associated would be pain, hematoma, seroma, and flap necrosis, and then also nerve injury. In terms of the cost, MRM can be covered under the Z package for the PhilHealth, which roughly the first case rate for MRM will be at around 22,000 pesos, and it's also widely available in the Philippines and is offered at PGH. The next operative option that we can consider as well for this patient, next slide please, would be breast conserving surgery as part of BCP. It's also standard care among those patients with early breast cancer. It provides better cosmesis without compromising oncologic outcomes as it provides equivalent survival rate with low recurrence as well. Similar to MRM, the risk associated are also those with general surgery, undergoing general anesthesia as well as surgery. However, there's an additional risk in case that we have positive margins during a BCS, we might need to re-excise tissue, and those with tumor size which are relatively big compared to the breast may not present with good cosmetic outcomes. Hence, there would pose an additional risk for reconstructive surgery. So in terms of the price, the first case rate for breast reconstruction surgery, specifically partial mastectomy with axillary staging, would be at around 22,000 pesos for first case rate. However, we have to remember that breast conserving surgery is part of BCP. Hence, there would be additional costs for radiation therapy and then for additional reconstruction, which for reconstruction surgery may reach about 55,000 pesos in general or average. Hence, it may exceed the Z package in case that's the primary mode of payment for the patient. In terms of availability, it's not as readily done compared to radical mastectomy, but it's also offered in PGH. Next slide, please. So this is one, we looked for one of the techniques of oncoplastic surgery for upper inner quadrant breast cancer. And this is one of the techniques which we found applicable for those with breast cancer, tumor size no more than 5 cm, who are candidates for BCS. It's a matrix rotation. So we can do a matrix rotation with or without periareolar skin deepithelialization as one of the probable techniques which we can use for excision as well as for breast conserving surgery for this patient. Next slide, please. So in terms of evaluating the result or outcome of the proposed treatment, we have both short-term and long-term outcomes to look for. In terms of the short-term outcomes, which we look for during the operation, we want to get adequate surgical margins, which means for this case, since it's a diagnosed invasive breast cancer, we want no income tumor for our surgical margins. We also monitor for post-operative complications for this patient. In terms of the long-term outcomes, as what Ryan told earlier, we want to look for the progression and recurrence, monitor also the patient survival, as well as not only those, but also his functional status as well as the quality of life and the patient satisfaction. Next slide, please. So for the current treatment procedures and outcomes done in this patient was underwent modified radical mastectomy on the left breast for 180 minutes total overtime during the 21st of July. Intraoperatively, we found a 4 by 3 centimeter left breast mass with an enlarged level 1 axillary lymph node. And as of yesterday, the histopathologic diagnosis is not yet available. Next slide, please. However, as it's already updated today, sir. So the final histopathologic diagnosis says that it's an invasive carcinoma of no special type, ductal in origin with histologic grade 2. The margins are negative for the tumor, However, 5 out of 16 axillary tail lymph nodes were noted with extranodal extension. Hence, the staging of the cancer was upgraded to pathologic classification T2 N2, which at METS 0 would mean that the patient has been upstaged to stage 3A. Next slide, please.
Good afternoon. Good afternoon. Yeah, good afternoon. I will be discussing on health promotion and prevention of breast cancer for our patient and for other women as well. So the final diagnosis prior to receiving the updated histologic diagnosis was invasive breast carcinoma left stage 2B, clinical T2N1M0, status post modified radical mastectomy left last July 2023 at PGH. So after a mastectomy is done, usually what the patient might ask is it done, doc? I consented to mastectomy. I had my breast removed. Is it game over? So next slide, please. So what we usually tell them is that after the breast has been removed, the tissue will further be analyzed for, let's say, tumor negativity in the resected margins, the positivity of the lymph nodes dissected, as well as the sensitivity of the tumor tissue for the various hormone receptors. So what we know about the breast is that the hormones estrogen and progesterone, they go hand in hand in facilitating the growth of the breast and the maturation of the breast tissue, the buildup of the lipids, and the maturation of your terminal ductal lobular unit, ultimately to allow the mother to be able to give milk or to lactate for her child. And this is all amplified by what we call the HER2 receptor, which is an epidermal growth factor receptor. Meanwhile, the breast is also drained continuously by groups of lymph nodes. What we know are 3 groups, namely the axillary lymph node, over here. Sorry. Right. So, well, I can't find the laser, but the axillary lymph nodes, and we also have the supraclavicular and the infraclavicular lymph nodes on top, as well as the inframammary group of lymph nodes on the sternal area. So in cancer, these 3 hormone receptors are also the 3 culprits that we look for in immunohistochemistry: the ER, the PR, and the HER2 receptors. And after mastectomy, we also need to look out for any kind of residual tumors that may not have been seen or resected in the breast tissue, as well as to look out for the contralateral breast for any recurrence of your breast cancer. So although an MRM has already been done in the patient, we must continue to empower them to check for any recurrences or any residual tumors being drained by the lymph nodes, as well as those that may appear on the contralateral breast. Next slide, please. So it might also help if we tell our patient, as she may be wondering why she got breast cancer at such an early age of 39 years old. So these are some of the risk factors, as highlighted a while ago by Bea, on what makes some people more prone to develop breast cancer than other people. So in particular, in our patient had a late parity. She had her first child at 32 years old, and she had a family history of breast cancer from multiple aunts and a cousin. So that by itself already increases her risk of developing breast cancer by 5 to 6 fold. So this is what we tell her, that you're more prone to develop because of your family history and late parity, and therefore it may not be so surprising that it happened at this point in time. Next slide, please. But to look out for any recurrences, we should also allow them to be able to help themselves. So in the Philippines, in this developing country, where a lot of women are busy and not all of them have the means and the time to actually go and have themselves screened outside, it is very good for us to allow them to learn something, to screen themselves for something that is cost effective, if not a cost nothing procedure that is accessible, that is easy to learn, and is replicable, that can be done by all women. And this is the breast self examination, or the BSE. Next slide, please. So the BSE can be done as early as 18, but we can start at around 25 years old. And it depends on what kind of, where you are in the reproductive age, or whether or not you're taking your OCP. So for the reproductive age group, you take it 5 to 7. You do it 5 to 7 days after your menses. For women on oral contraceptive pills, you do it before starting a new pack of pills. And for women who are postmenopausal, you do it on the last day or on the first day of the month. Basically monthly, but it depends on where you are. So next slide, please. So for the BSE, what we can tell our patients is that, each month what you can do is you can go in front of the mirror and you can check your breasts. So there are two things that you have to look out for when you're doing a breast self exam. The first one is inspection, and the second one is palpation. So for inspection, you can look at the mirror with your arms down, and then followed by your arms over your head to add tension to the ligaments to accentuate any kind of skin dimpling or any skin changes. And you look for changes in breast symmetry, changes in skin dimpling, orange peel appearances, or nipple inversions. Next slide, please. And then after you're done inspecting your breast, what you can do is you can start your palpation. So I got this from the one of the websites of Dr. Hoson. So usually what we can do is to place our arm over our head for the women, and to palpate the breast in a clockwise position using the second and third fingers, or the second or fourth fingers, gently, firmly, and clockwise. So you can start with the upper outer quadrant, followed by the upper inner quadrant, until you finish all the quadrants of the breast. And you can explain to them that given this figure of with the quadrants of the breast, see here the percentages of where the breast tumor is most likely to be seen. So a lot of the breast tumors are at the upper outer quadrant, half of them, 50%, and the others much less. And there's about an 18% rate of breast tumor occurrence around the nipple areolar complex. Now, after the patient is done with the quadrants, before looking at the axillary region, we can ask the patient to actually pinch the nipple gently to look for any kinds of nipple discharge, and then to proceed with palpation of the axilla on a rest arm, sliding your hands, your fingers downwards to check for any kind of axillary mass. So next slide, please. So in general, to allow our patients to be able to help themselves via screening, we should teach them on how to do a breast self-exam every month, depending on the reproductive status of the patient, as well as their use of OCPs. And that can go hand in hand with physical examination of the breast, or a PEB, which is done by a clinician or a qualified health personnel. And then the patient, aside from that, can also undergo screening mammography annually, which usually starts at age 40 for low risk or age 25 for high risk patients. And we can tell them that if you see any changes or if you feel any lumps, that you consult a breast specialist, because even to this day, 2023, the best way to treat breast cancer effectively is to catch it early and to treat it early.
Okay, so we'll move on to our journal critique. Wait lang po. Okay. Okay. AG.
Okay, so if we recall, our patient was diagnosed with early breast cancer found intraoperatively within the large level 1 axillary lymph node. So we've thought of this question or this scenario po before receiving the histopathological diagnosis today. So in the management of non-metastatic breast cancer, again, we recall that radiotherapy is used, and its use depends based on tumor margins and as well as the axillary nodal status. So our question was, while we know that post-mastectomy radiotherapy, there's consensus that it's recommended for women with breast cancer with 4 more lymph nodes, there's yet an international consensus to be made for those with 1 to 3 affected nodes. Hence, our clinical question being, among women with early stage breast cancer with 1 to 3 positive lymph nodes who underwent MRM, does the post-mastectomy radiotherapy reduce recurrence and improve survival compared to those who did not undergo radiotherapy? Next slide. So this is a search strategy the team made. In general, we had 7 search returns, 6 of which are clinical trials and 1 of which is a systematic review. Hence, we chose a systematic review out of the search findings. Next slide, please. And this is the paper that we saw, which was published on the Cochrane Library regarding post-mastectomy radiotherapy for women with early breast cancer and 1 to 3 positive lymph nodes. Next slide. So we first appraised the directness of the study to be if it's direct enough to answer our clinical question. For this case, yes, we saw that there is that the study is direct enough to answer clinical questions since the PECO matches that of the clinical question from the journal article. Next slide, please.
So in the next portion of appraising the article, we appraise the validity. So there are 4 questions here. The first one being, were the criteria for inclusion of studies appropriate? So our answer there is yes, because as mentioned just now, we compared the PECO of our clinical question with the question that was answered by the article. So there, the population included women with breast cancer, 1 to 3 positive lymph nodes that underwent mastectomy. So the second question is, was the search for eligible studies thorough? So the important part here is that we not only include published articles, but we also have to look through unpublished clinical trials, because we should not just include the published ones because there's more bias towards positive results when publishing. So in the study, they mentioned that they searched different databases such as Cochrane Breast Cancer Groups, Specialized Register, Central Medline, MBase, WHO International Clinical Trials Registry Platform, and clinicaltrials.gov. So these last 2 actually include the unpublished studies and clinical trials, which are important to go through as well for going through systematic reviews.
So the next question we answer in appraising for the validity is, was the validity of the included studies assessed? So our answer is yes, because based on the appendix in the systematic review, the 3 studies that were included in the review were assessed for their validity, including checking for the following aspects: the random sequence generation, the allocation concealment, the blinding, follow-up, and the reporting. And lastly, we also ask, were the assessments of the studies reproducible? So the basis of this is there has to be at least 2 independent reviews, and based on the review, there were 2 independent reviewers. As you can see, it's quoted There were two review authors, RV and MC, who looked over the studies identified from the search strategy independently.
Okay, so the next step is to appraise the results. And the first question we ask when appraising the results is, what are the overall results of the study? So in one study, in a 2007 study by Overgaard et al., so they reported lower local and regional recurrence rates and increased overall survival using modern day radiotherapy practice. While another randomized control trial, so one study by Kilander et al., also in 2007 reported increased disease-free survival, albeit they used obsolete RT regimens. And the next question is, were the results similar from study to study? So however, we still cannot say because only one study was able to provide results that satisfy the primary and secondary outcomes of the systematic review. Hence, the similarity of the results between studies cannot be properly appraised.
Okay, so for the last question, we want to ask how precise the results were. Usually we look at this at the forest plot, but since only one study was able to provide results that satisfy the primary and secondary outcomes of the review, we still also cannot say how precise the results were. Hence, due to a paucity of studies on the topic, because this Cochrane review was done in 2023, the current strength of the evidence of doing post-mastectomy radiotherapy in women with early breast cancer and low volume axillary disease is low. So we have to take that into consideration when we inform our patient of this option after her mastectomy.
Lastly, we appraise the applicability of the study. We look at any biological or environmental factors that might get in the way of applying the results of the study to our patient. So for sex, there are no issues because all participants in the review were female as our patient. For comorbidities, the study made no mention of any concurrent comorbidities of the study participants. Our patient herself has no comorbidities, which may reduce the effectiveness of radiotherapy theoretically. For age and race, all participants, regardless of age and race, were included in the review, which may affect the applicability of this review to our patient because patients of different ages and races may have different responses to radiotherapy due to genetic or environmental factors. For pathology, the study included patients with early breast cancer and found to have 1 to 3 positive axillary lymph nodes, which matches our patient's disease. However, all tumor sizes and histological types were included, which may affect the applicability of this review to our patient. For socioeconomic factors, the study made no mention of any socioeconomic factors such as access to radiotherapy and compliance with dosing schedule. For our patient, difficulty complying to the radiotherapy schedule due to work, other responsibilities, or logistical concerns may be a factor that can reduce the effectiveness of RT. So for individualizing the results to our patient, so while there are no issues with the correctness, validity, and applicability of the study to our patient, the evidence in the systematic review is low because it only appraises one RCT for effectiveness. And while having a dialogue with the patient, we should explain these results to the patient so that she can make an informed decision of whether to proceed with radiotherapy or not. This ends our presentation. Thank you very much, Bob.
Okay. Thank you. Thank you for the extensive preparation and also your presentation. Okay. And then thank you also for trying to follow the template that I gave you. I hope you appreciate that. Okay. So you may not have a perfect presentation based on the template, but at least I hope you get some tips on how to improve your patient management process. Okay. So let's start with the journal first, journal critic. Okay. 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 So this is from Cochrane. Yeah, okay. But before that, what was the primary outcome? It's the survival rate and also the local recurrence rate.
Yes, sir. The primary outcome is local regional recurrence rate, and then secondary outcome was overall survival, sir.
That's the secondary overall. Okay.
Yes,
So only one study.
only one study.
Only one study. Did you look at the one study? No.
Briefly, sir. I looked at the abstract.
Okay. Meron? Is this the one?
So this is the original.
This is the systematic review.
Yeah.
Okay. There was a summary there by ano. Who's the author of the yung ano, yung one study?
Overguard po, sir.
Oh yeah, Overguard. Ano yung ano niya? Ano yung findings niya?
Results slide.
Yeah. I think it was presented earlier.
Yes, sir.
Flash lang.
So there's one study from Overguard reported lower local regional recurrence rates, hazard ratio of 0.2, and increased overall survival, hazard ratio 0.76, using a Moderdane radiotherapy practice.
0.2 and 7.76. Okay. This is for stage T2 and 1, huh? T2 and 1. Okay. Okay. So only one study. So when you advise your patient, you just have to say that there's only one study, but the others, so that means because Cochrane is it's a review of it's a systematic review of a lot of journals, no? Okay, and then so when you do a journal appraisal related to your clinical questions, yeah, one approach is to look at the Cochrane study, if there is a Cochrane study, because it's more powerful, kasi marami na, no? Okay, so more efficient, no? Or you can look, if there's no Cochrane, then you look at an individual study, no? Usually if it's a treatment study, treatment questions, then you look at the RCT, no? As a priority, no? Okay. So dun sa Cochrane, they cannot, minsan very diplomatic din ng Cochrane, no? So they don't like to really commit anything that without a strong basis. That's why they said they cannot conclude because there's only one study, no? Okay. But you now have to look at that one study, because this might be the basis for your recommendations to the patient, no? Okay. So there are two things I'd like to mention here. Number one, okay, a lot of times if we don't have the data, you just have to use the, what do you call that? The so-called common sense, no? Okay, so what is the usual effect? Example, what does RT do? Okay, what does RT do? In general, we know that it's a local control modality, no? Okay. So how will it control the cancer, the breast cancer in this particular patient? No? How will it improve the survival? How will it improve the local recurrence? No? Okay. So you try to analyze it yourself. Just parang ano lang, the ordinary, parang I just put open close quotation marks common sense. I cannot get the right word for that. Huh? But other authors, other writers will frown on my using the word common sense. But what I'm trying to say, just ano ba yung usual, no? Okay. So we know that RT is a local treatment, no? So RT usually used for the chest area, the breast tumor, okay, and or the axilla, or sometimes in the clavicle, okay. Supraclavicular for the lymph nodes, no? So local treatment modality yon, no? So usually ang effect noon will be local recurrence, local and regional recurrence. Na? Okay. Now, if you have, so yung systemic overall survival, most likely mahina yon, na? Okay, we know breast cancer is systemic disease, na? So mas effective siya sa local control, control of the local and regional recurrence, okay? So, but the question now is, you have done surgery on this patient, na? If you have a good margin, na, do you need RT to add RT to prevent the local, to decrease the incidence of local and regional recurrence. Na? Okay. Ginawa na yung total mastectomy rito, di ba? Total mastectomy and axillary dissection. Na? Okay. That's why in breast conservation, kasi hindi tinanggal lahat, no? So they would add RT. Tama? So that's the logic behind that. No? Okay. So you can, if you look at the stage, if it's total mastectomy ginawa, then you can advise the patient, pwedeng wala na. Okay. So probably walang masyadong effect, na. Okay. Walang masyadong benefit, na. Okay. So that's what I usually do in practice, is I do a total mastectomy, and my margin, kahit na mag-total ka, kamisan, the margin is close to the tumor, then you may suggest a local additional radiotherapy. No? But if the clearance is clear, so it depends on the surgeon doing the operation also. If the clearance is clear, no, very clear, no, then you don't need to have the RT anymore. No? Okay. So you just, kasi ang problema naman sa breast cancer, it's the distant recurrence. Na? So you can just observe that if there's a local recurrence on the chest wall, no distant recurrence, then you might add an RT this time, na? After the operation, after observing, after following up the patient. Na? Okay. 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 Any question on my comments? So if you use the BRCA, sabi mo, okay, B, benefit in terms of local recurrence after surgery. Konti lang, probably, kasi may ginawa kang radiotherapy, most likely may konting benefit, no? But how significant is the benefit, no? So you can say +1, okay, or +2, but +1 or +2, no radiotherapy, probably the risk of recurrence will be +1, no? Okay. Or 2 naman, kasi you're using some symbols, no? So +2 ang local recurrence, kung radiotherapy, babawasan yung isang 1 point, no? 1+, no? Okay. Then in terms of risk, so you also tell them the risk of the radiotherapy, diba? Okay. So what are the risks of the radiotherapy? Radiation to the wall, to the chest, usually. Anong side effects ng radiotherapy? The side effects will be burns, no, initially, okay? But you tell them that burns will disappear after 1 month, 2 months, no, okay? Then the other possible potential side effects will be on the lungs, on the deeper organs, no, the lungs and the heart, no, okay? But you can say those are possible, but these are not. You have to tell them frankly that these are not very significant, no, okay, acceptable, no, okay, but theoretically they can occur, no? Okay, but for no radiotherapy, so you don't have the burns, you don't have the side effects on the heart and the lungs, no? Okay, then the cost, you tell them the cost, no? The cost will be how much, okay? So it's nice that we have the PhilHealth now, pero don't rely on the PhilHealth, because the PhilHealth will not be able to cover everything, especially in the private hospital setting. No? Okay. So usually they will still spend about 30 or 40,000 in the private hospital, despite the presence of PhilHealth. No? Okay. So in the government hospital, most likely the PhilHealth can be the cost will be covered by the PhilHealth. No? Okay. Pero may kapalit yon. That's why the cost, you have to input the inconvenience of waiting for the schedule in the government hospital. Okay. Ang tagal, di ba? Okay. So So you have to give them the data. Then every day they have to go there. The inconveniences of going to the hospital for 6 weeks. No, okay, usually 6 weeks. And then okay. Then availability, if they live far from a center, that's another consideration. If they're in the city, no problem. No, but not all hospitals have RT facilities. No? So you give them this data, BRCA, and then tell them, what do you want? No? Okay. Ask them first. After giving them the data, let them choose. Try to choose. They usually ask you back, what do you think? Okay. Okay. They always ask the doctors, kayo ho, doctor, anong sa palagay ho ninyo? Okay. So to help them answer these questions, at this time, after interacting with the patients, you must be able to assess the number one, the psychological makeup of the patient, the personality niya, no? Kung talagang over-anxious siya, gusto niya yung maximalist, lahat gagawin, no? Okay. And then the other one will be the financial status also, no? Okay. Then the third one will be yung mga mindset niya kasi marami siyang naririnig, di ba? No, ganon, no? Nag-RT, ganon, no? Okay. So input all those things, then you tell them, okay, kung sa'yo, kung takot na takot ka, at hindi mo mawala sa isipan mo na pwedeng umulit, no? Kung gusto mong parang security blanket, you can go for it as long as you can afford the cost. Okay? Saka inconveniences, no? Okay? Then after that, they decide. Okay? So wala ka na doon. May informed consent ka na, no? Informed it's either informed consent if they agree to it, if it's informed refusal kung ayaw nila, you're free from all the from your yung mga responsibilities that you did not explain everything to them, no? So it's their decision now, no? Okay. Okay. Now the other thing that I forgot about the complications of radiotherapy is the lymphedema. Okay. Okay. Lymphedema is a very significant complication. After a modified radical mastectomy, you did an axillary dissection, di ba? So you more or less compromise the lymphatic supply channels there. You remove some of the nodes there. No? So now, if you add radiation, you might aggravate the decrease in the flow of the lymphatic channels. There might be fibrosis, obstructions. Okay, so there's a higher incidence of lymphedema after RT, especially after a axillary dissection. No? And the lymphedema is usually permanent. No? So take note of that. No? Kahit na may mga measures to decrease it, to mitigate it, like yung mga stockings, no? Lifting the hands over the head. No? Okay. So andyan palagi yun. No? I've seen patients who survive for 20 years but suffering from lymphedema. No? Okay. So, ibabalance pa lang. Kung talagang hindi kailangan, no? Based on ito, one study lang, o then looking at the local situation, no? So if you are not the surgeon, if you want to advise, you look at the margin of the tumor, of the no? Sa histopath, no? But the best person to decide on that will be the surgeon. No? Okay. Kasi the surgeon can say, I have a clear margin, but once they submitted the specimen to the pathologist with some distortion, so sometimes the pathologist reported that it's very near the tumor, but in fact, it's not near. No? Okay. So the actual situation will be given by the surgeon. That's why kumisan mahirap din magpalit-palit na mga surgeons, no? Okay, dapat yung surgeon who operated on that patient will be the best person to tell them what really happened during the operation. No? Okay, yung mga reports afterwards, medyo may konting distortion yan, no? Okay, hindi siya accurate, no? Okay. So any question on the okay, as a matter of practice, I don't usually give RT, no? In general, after I have done a clean operation. Okay, clean axillary dissection and also clean total mastectomy. Na? Okay. Then, if there is a need for additional treatment, I usually give chemotherapy rather than radiotherapy. Na? I'm more concerned with the systemic metastasis. Na? Okay. Okay. Yung local, pwede namang ano pag nag-local, you can still run after it, you can excise it as long as there is a close follow-up. If there is a local recurrence, you can still run after it, do a wider excision, or if it's a local recurrence that it's hard to excise, then that's time you can add RT already, radiotherapy. Na, okay, okay. So questions before we leave the journal? So somehow this stimulates me to think. I've been thinking, how come a lot of my colleagues, especially the colleagues like surgeons and also non-surgeons, they usually give RT after a total mastectomy and neck axillary dissection. I always have that question, no? But in my practice, I don't do that, no? Okay. So this particular activity today, this will prompt me to do more study on RT even for T3, na? T3 lesion. Kasi kung T3, kung minsan, because the breast is big, you can still have a good margin, na? With T3, na? Okay. Okay, any questions? Throw me at least 2 questions. Anybody? Challenge me to answer your questions. Kung walang questions, comments. Whether you agree with my observations.
Oh, sir, just a curiosity lang po.
Okay, Reg.
Is there any special case po when you would actually give radiotherapy after a mastectomy po?
Is a special case? Case, yun nga. If the margin is very close, no, then you cannot really observe the patient well. No, so after operation, I usually ask for checkup, lifetime checkup. No, I don't throw, as a surgeon, I don't throw it to the medical oncologist. No, I still follow up this patient. No, okay. So if there is a margin is close to the incision, the tumor is close to the margin, to the incision, and then patient cannot really follow up. No, okay. And then yung mga breast conservation, actually yung breast conservation because of the recommendations, no? But strictly speaking, at times I just do a wide excision and then just observe without an RT, no? Okay, if there's a local recurrence on the side, we just run after it. This time, we can do another wide excision for the local recurrence kung maliit lang, or this time a total mastectomy already. Okay, okay. But everything will be done with the information given to the patient adequately and clearly for an informed consent. Na? Okay. Okay. So margin is importante doon, ha? Margin, Reg, na? Okay.
Sir, I also have a question for this case. So for this patient, sir, 39-year-old T2N1M0, if she wants breast conservation with RT, sir, will you recommend it as an option for this case, sir?
Yeah, but I will present the yung benefit risk cost availability of all these 2 options, the total mastectomy and the breast conservation. No? If she's the type who doesn't want to lose her breast, no, okay. And then kahit na anong sabihin mo yung disadvantages of the breast conservation, and then if she's willing to undergo the radiotherapy, no, go ahead, no, okay. So actually it should not be me who will be deciding. No, I give them all the data. No, and then if they choose, if I feel that they're choosing the wrong option, then I will try to educate them some more. Kasi kung minsan hindi nila naintindihan masyado, no? Okay, o kaya na-overwhelm sila by some anxiety, by some mindset, gano'n. Then you try to educate them until such a time that you think na you tried your best, no? Kasi there are patients who really, kahit anong explanation mo, hindi pa, they just stick to one option, no? To a particular option. Okay? So this time, kung pwede naman yung option na yon, as long as they agree to all the costs and inconveniences, okay na sa akin. I will agree. No? Okay. Basta importante informed consent lang ito. No? Okay. And then in the end, it's the patients who will decide. No? Okay.
Okay, sir. Thank you.
Actually, sir, a follow-up question lang po
Sure.
on Raf's question. Sorry. In that case po, if she decided po to go through breast conservation therapy, there would be a frozen section done first po, sir? Or would you offer, or would the frozen section be done po and then maybe a mastectomy after if ever na whatever turned up po sa frozen section?
Yung frozen section, your question is based on the premise that the frozen section will tell you whether it's CA or not? O may
Yes,
meron na
sir.
siyang diagnosis eh. She has a core needle already, right?
So there's no need for frozen po.
The only thing that I'm thinking of when you ask that question is what you want to know the margin, no? Margin, so you do a
Yes,
frozen section kung adequate ang margin mo if you want to do a breast conservation, no? Okay, so pwede yon. Pwede, that's an acceptable reason for doing a frozen section, no? But some surgeons, no, would just do a margin of 1 centimeter or 2 centimeters that will ensure that talagang negative na. Okay, so you don't need a frozen section anymore, no?
Okay, sir.
But there are some
Okay, sir.
surgeons who are afraid baka positive pa siya, then frozen nila, no? Frozen
Okay.
for the margin, this is frozen section for the margin. If
For
you
the
want to do-
margins.
yeah, if you want to do a
Yeah.
breast conservation, no? Okay.
Okay. Okay, sir. Understood. Thank you.
Sir,
Then
I
you
have a
apply mo rin,
question
ha?
po.
For everything, basta for every problems that you encounter, apply the BRCA, na? Ikaw, frozen, walang frozen for the margin, di ba? So what are the benefit, di ba? Benefit, okay, with frozen section, meron kang information, na? Okay, but for the no frozen section, wala kang histopath information, na? Microscopic information. But you still decide, na? Whether it will yung tinatawag na statistically significant saka clinically significant, na? Di ba there's a difference there, na? So kung ang experience ng surgeon with the 2 cm margins, ang batting average niya is 1% lang magiging positive, no? Wag na lang, di ba? Okay. Kung mataas, let's say 20%, then go for the frozen section, na? Okay. So you still have to qualify, na? Okay. And then after that, the risk and the cost, okay? Kasi magpo-frozen section ka, may additional cost pa rin yan, di ba? Okay. Okay, in the private setting, it will cost you about 10,000 more, okay? Or even more, na? Okay. Okay. So i-apply mo yung palaging i-apply mo yung BRCA, na? Yung A is still there, no? A availability, kasi walang pathologist to do the frozen section. No, okay. Okay, somebody was, Raf, ikaw ba? Sino ba?
Me, sir.
Sino? Okay.
Yes, sir.
Nielsen. Okay, Nielsen.
I was just curious if, like, yung parang your practice consensus of not offering radiotherapy was there from the start, or was there like some studies na nag-change ng opinion niya, sir? Because nga, you said na a lot of other surgeons would offer radiotherapy after their own surgery po.
Yeah, so your questions is on my
Like,
the origin of
did it change?
my practice.
Yes, sir. Like, when did you decide na you won't radiotherapy, or was it always your opinion from the start po?
Okay. Thank you for the challenge. Challenging question. Okay, number one, logic mo na. Sabi ko, local recurrence ang kalaban mo dyan, di ba? Okay, with RT. RT, you want to control the local recurrence. Okay, so sa akin, kung maganda yung margin ko, no, hindi na kailangan. No? Okay. Number two, based on experience also. Over the years, if you accumulated 2,000, 3,000 of all these things without RT, no? Okay. Let's say ang recurrence rate mo is only 1 to 2%. No? I'm not saying I'll be telling a lie if I tell you zero. Hindi pwedeng zero. Okay. So 1 to 2% lang, no? From my experience. No? And then kung mag-recur siya, then I run after it. Masasalvage ko pa. No? Pwede rin. No? Okay. So practically 3 reasons for that. No? Okay. You can salvage pa. Basta may close follow-up. Kasi ang practice ng some surgeons, this is part of our community issues for the case discussion here related to community issues. Some surgeons, after the operations, they just throw it to the medical oncologist. No? Mahala na sila doon. No? But usually, although recorded ito, this session is recorded. No? But in reality, to tell you honestly, a lot of physicians, they don't do palpation of the breast. No? Oh, okay. Let's say yung mga hindi nila kasi once you have a checkup after the operation, you still have to palpate the chest wall, the breast, di ba? Okay, so a lot of times they just rely on the ultrasound, mammography, CT scan without palpating, no? Okay. Okay. So importante pa rin ang palpation. And the best person to do the palpation will still be the surgeon, di ba? Kung ano. Okay. Pero kung pumunta sa medical onco, dapat pinapalpate din, di ba? As physicians, no? Okay. And then, okay, medyo tagal lang konti, but I just want to input. Last night, I have a telemedical consultation with my nephew in Taiwan. No, she said she has a neck problem, thyroid. No, so she went to see an endo. Sabi ko, I asked her, did the endo palpate your breast, your neck? No, hindi. No, they just look at my ultrasound, my lab results. So I thought it's only in the Philippines. That's what's happening in the Philippines. Halos konti lang nagpapalpate. They just rely on lab. So in Taiwan, they also do that pala. No? I think it's true all over the world. Baka. No? Okay. Okay. Okay, let's leave this already. Let's leave this.
Sir, may I ask one last question?
Sige.
Sorry. When you give advice to a patient, do you find it helpful to have certain like specific figures at hand? For example, like with this treatment modality, like survival is improved by this much, or do you usually just give like ballpark figures lang, sir?
Sa ngayon, ballpark, unless those that I'm familiar with. No? Okay, I hope I will still be alive because that's my plan for the next 5 years. To put down all the data, specific data, including the cost. Kayo, di ba yung cost ninyo? Wala, halos, a lot of doctors, even surgeons, they don't know the cost of how much this patient is spending, di ba? Okay, so lalo na kayo, no? And there's no data on that. You cannot rely on the PhilHealth lang. Okay, so you have to know what the running rate of the, I think may mga websites, yung mga blogs na how much is the cost for this thing, operations, di ba? Meron, di ba? Okay. So I will try, no? Pero kung minsan when I blog the cost, binablock ako ng Facebook no? They don't like you to input the prices of even the medicine. I put down the list of medicine and then the comparative cost. So they will say that it's against our community standards, no, to list down all the costs, all the prices. Nabablock ako doon. Okay. But do you agree? We have to know the cost, di ba?
Yes, sir.
Okay.
Yes, sir.
Yung second best na kung second best pero mas mura kaysa dun sa first best option, pero ang laking agwat, you can still go for the second best first. Because there's no guarantee in everything anyway, no? Tama?
Yes, sir.
Okay. Okay. Thank you for all those questions. Let's now go to the, baka maubusan tayo ng oras dun sa paper itself, the case. Okay. So the case, let's start with the pattern recognition, the diagnosis. Sinong nag-present sa ano? So yung sa history, you mentioned 10 o'clock, na-identify na nyo kagad yung 10 o'clock. But because you have access to the records, no? So when you do a history, usually, nasaan ba yung bukol ninyo? Kaliwa, di ba? No, usually, you don't usually ask, nasa 10 o'clock ba? Nasa 9 o'clock ba? Diba? Okay, you just go direct to the physical exam and then be the one to determine it, no? Okay, so it may not be part of your history anymore, no? It's part of your PE, no? Okay, a small comment. And then, I did not see the ultrasound report. Mamo, you did not present it?
It
No,
was
sir,
done elsewhere, sir.
ano po, yeah, outside na, sir. So wala
Outside of
kaming
PG.
access.
Wala kayong access. Important.
Yes, sir.
Pero by Reg 5,
Yes, sir. Yun yung nasabi po nung patient, sir. Parang nasa history na rin, sir, nung chart niya yata from the BCC, pero hindi po namin ma-access yung actual ultrasound report.
okay, so importante pa naman nga yun for discussions because this is a community concern, no? On the mga ultrasound mammo reports, no? Okay, okay. Anyway, mamaya ko na, if we have time, I will discuss it, no? Yung mga community concerns on ultrasound in mammo, no? So let's go to the diagnosis, no? So the primary diagnosis you mentioned is CA. Secondary diagnosis is fibroadenoma. Okay. So you have a different approach in trying to justify your primary and secondary. But in my video, I told you about the pattern recognition and the prevalence, right? Pattern recognition and prevalence. As the two processes that you use to come out with a clinical diagnosis. No? Okay, so you might ask, where did this come from? Ito yung recommendation ko. It came from me because I'm not satisfied with the teaching before, or there's no so much teaching on how to process, di ba? They call it hypothetical deductive reasoning. But what is it? No? Ano ba specifically, ano yung ibig sabihin ng hypothetical deductive? How do you apply it? Diba? Okay. So yung sa akin, I just put it pattern recognition. Pattern recognition means you recognize a picture, clinical picture, history, signs and symptom data that will be reflective of a particular disease. No? So that's a pattern recognition. You recognize the pattern for a particular disease, then that's your diagnosis, di ba? That's your first suspect. Easy to understand, di ba? Pattern recognition. Okay? Then, since there are a lot of, wala namang, although we've been using the word pathognomonic, na, anong ibig sabihin pathognomonic? Anton,
like
Characteristic. Oh.
Sige. Reg, anong Reg? Sige, Reg.
Like, based on my understanding, it's characteristic of a certain disease or pathology.
Usually, when you say pathognomonic before, ang aking intindi, pag may itong sign ito, sigurado ka na. 99% yun na yun. Na? Okay. Pattern recognition din yun. Pero sasabihin niya, 99% na yan. Na? Sometimes I said 100%, but as I said, my philosophy, there's no such thing as 100% in medicine, di ba? So 99%. Parang Parang sure na yun, no? Ganon, no? But we know that there are a lot of diseases that will present with the same set of signs and symptoms, halos pare-pareho. Tama? Just like during the COVID and flu and other upper respiratory tract infection, di ba? Pare-pareho yung symptoms, di ba? Okay. So why did we diagnose COVID during the COVID pandemic? Na pag mayroong mga symptoms of flu-like symptoms, we said that most likely this is COVID. Na? So the second process that you use is the prevalence. Okay, that's why I use the word prevalent. Na? Okay, because at that time, COVID is very prevalent. Kaya yan ang pipiliin mo. Okay, yung secondary diagnosis mo will now be the flu. But before the advent of the flu, COVID, flu ang number one mo, di ba? Ganon. You see what is meant by when I say prevalence? No? Prevalence is the prevailing incidence. How common is it in the locality, a particular disease, okay, or in a particular age group, okay? So in this particular patient, yung 39 mo nasa borderline, di ba? But if you say the patient is 20, okay, most likely you are quite certain it's really benign, di ba? If there's a breast mass there. If it's a patient is 70 years old, most likely it's common in that age group, breast cancer. No? Okay. But in this particular case, nasa borderline, di ba? 39, we don't know the exact cutoff, di ba? Okay. But at least we know, we don't have to invoke the female, okay, in terms of prevalence, okay? Okay. So, kasi I mean, you're not discussing male, female. In general, we don't use the comparison of male, female na sa mga breast masses, no? Okay. So we know that for a fact that breast masses, breast disorder is common in the female. Ang starting point din to look for the kung sa prevalence is usually the age, no? The age, no? Okay. Kung gagamitin may prevalence process, no? Okay. Okay. And then in the locality also, no? Okay. Kung TB, okay, I'll jump the gun. Kung TB is very common, let's say 10, 50 years ago, kung TB is common, na, can you put TB as your number one? If the premise is that TB is very common, can you put your primary diagnosis of TB, na? Pwede, di ba?
Yes.
Okay. Okay. So that's what I meant by prevalence. You invoke the prevalent process, but this is after you put priority on the pattern muna. Okay. Okay. Put priority on the pattern to make a diagnosis, and then put the prevalent process to either negate or to reinforce it. No? Okay. So in this particular patient, ang starting point nito is a breast mass. So it could either be benign or malignant, right? Okay. So what are the signs and symptoms that you will look for that will make you suspect either it's a benign or malignant, or what is there a pattern for malignancy? Is there a pattern of benignity? Na? Okay. Okay. Kung merong pattern for malignancy, your diagnosis, your primary diagnosis should be cancer, breast cancer. No? And then you reinforce it with, in this age group, 30, 39. Pwede pa. No? Nasa borderline, pwede pa. It's possible. No? But if this patient is 20 years old, no, magdududa ka. Di ba? Okay. If it's 70, tama yon. Okay? Mas certain ka na. Di ba? Okay? Or 60 or 50. Ganon, no? Now, what are the pattern for malignancy in this particular patient? Number one, is there a sign of malignancy will be nipple inversion. Okay, that's a sign of invasion of a tumor. Di ba? Tama? Number two, the presence of spread. which is the axillary node. Okay, so just these two alone is already a pattern for breast malignancy. Okay, yung hardness, medyo mahina yon because it's very subjective, no? Because to some patients, to some physicians, hard siya, kung iba soft, iba-iba, di ba? Okay. Okay. Number two, yung mobility can also be present in the early stage breast cancer. Okay. If it's fixed, then that's a sign of malignancy. But if it's mobile, it's not indicative of anything. Okay. Para 50-50. Okay. And then signs of local invasion, kung may retraction, no? Fixation, retraction, and then lymph nodes. Okay, those are the signs for malignancy. Okay, just one sign is enough. Kahit na walang lymph node siya, merong inversion siya, which could be a sign of local parang invasion of the local tissue of the nipple. Then you commit yourself to a primary diagnosis of breast cancer. Okay. Okay. So what are the signs of benignity naman?
Sir, it can be the fact na if it comes and goes with the woman's menstrual cycle, that can be a sign of being benign. Also siguro,
if the mass is not dominant, let's say medyo lumpy lang, pwede, di ba?
yes,
But
sir.
this one, it's already a 3 centimeter, at least 3 centimeter mass, dominant mass. I don't think it will come and go anymore, di ba? Okay. So, yung sinasabi mo, pwede in patients in which you are doubtful, is it fibrocystic or is it a pathologic mass, na? Okay. Okay. So, ano pa yung mga sign of benignity?
Sir, the lack of skin changes, the fact na walang retractions, walang dimplings, if it's just purely a mass. Yeah.
Sige. So, by elimination na lang. Kanina, I started with the signs of malignancy. Kung walang sign of malignancy, benign. Okay? That could be one approach. Okay? But to reinforce that, is a reliable sign of benignity or benign will be the cystic nature of the mass. Okay? So, ito solid siya, di ba? But as I said, kung solid siya, pwedeng benign, pwedeng malignant pa rin siya. Okay? But if the mass is cystic, meaning when you press on it, it's fluctuant, now it's depressible, most likely it contains fluid, because at 3 centimeter or 4 centimeter mass, medyo malaki na yan, madaling elicit yung now whether it's solid or cystic. Okay, but for the smaller masses like 1 centimeter, mahirap i-elicit yung cystic nature of the mass. No? So once you decide that the mass is cystic, now in this 39 years old, na walang nipple inversion, walang lymph node, now then your diagnosis is right away a macrocyst. Now, so you're using a pattern. Now, first, you eliminate the signs of malignancy. Number two, you go direct to the point that there is a sign of benignity, which is cystic. Now, so yun lang ang, I think so far, this is the only sign of benignity that I'm banking on in all my patients with breast problems. Now, if I see a cystic mass, now I would tell them most likely it's benign. Now, okay. So that's the same. Okay, let me input na yung ultrasound. So, konting ano lang. All of you have seen a report of an ultrasound before, I suppose. Okay. So in ultrasound, they try to determine whether it's solid or cystic. Diba? But the moment they put the word cystic, usually they don't put BI-RADS 4 or 5. Now, okay, it's really more of benign. Now, okay. It's on the solid, when they see solid area, then that's the time they have to decide whether it's BI-RADS 4, BI-RADS 3, BI-RADS 2. No? Okay. So cystic nature of the mass is a reliable sign of benignity. Okay. in the breast, no? And practically in all surface masses, no? Okay. Okay. Signs of, okay. Then signs of inflammation, alam na ninyo, no? If there is redness, if there is pus, no? Right away, you diagnose it as mastitis, breast abscess, di ba? Okay. So ang approach, if I were to give you an algorithm, if you have a patient with a breast problem, with breast mass, now you look for signs of inflammation first, okay, which is very easy to recognize. Kung wala, you're left with signs of malignancy versus benignity. Okay, so the approach is to look for signs of malignancy first. Kung wala, then you settle for benign. Okay, and then try to check kung may merong cystic finding ka doon sa breast mass mo, then all the more think of a benign condition. Okay? So the approach there is you look for yung pinaka-easiest sign to recognize, which is inflammation, easy. Malignancy is also easy. Yung benignity, mahirap hanapin yun, no? Pero by elimination ka na lang, na? Okay? So that's what I meant by the pattern. Kung yan ang gagamitin mo for the pattern, wag mo nang invoke yung if you want to invoke the prevalence, okay, sandali ha. So that's a pattern for breast cancer. You have nipple inversion and then you have a lymph nodes, okay? And then what will be your secondary? As we said, wala namang wala namang 100% palagi, di ba? So you must have a secondary. When you put up a secondary, it should be the closest possible. Now, okay. Does fibroadenoma present that way? O wala na kayong maisip na iba. Kaya fibroadenoma na lang. Because it's a more common benign condition. So you look for other diseases that can present with the same picture. Okay. Sa ngayon kasi, yung breast cancer, we only stick to one entity, breast cancer. But in, let's say, in thyroid, we can have papillary cancer, you can have follicular cancer, no? Okay. So you can have papillary as number 1, follicular as number 2. Ano, no? Pero sa ngayon, sa breast, we lump them together. Breast cancer or not breast cancer. Di ba? Okay. So, but you have to come out with a secondary diagnosis, which is usually benign, no? Kasi opposite ng cancer is benign, di ba? So, but you must come out with an entity that will present with the closest picture of what the patient has, which is invasion and then lymph nodes. A nipple inversion and then lymph nodes. Ano?
Sir, I was thinking phylloides tumor din po.
Phylloides. Okay.
It could present with nipple inversion po.
Okay. Pwede. And then,
Yes.
how do you consider the lymph nodes?
Sir, based on my understanding po kasi of phylloides, it can either be precancerous din po, no? So, if it...
Pwedeng malignant, pwedeng benign,
Yes.
di ba?
Yes, sir. Parang spectrum din po siya, if I remember correctly po. So, there may be lymph node involvement din po in phylloides.
Okay. So if you, okay lang yan, ha? Okay. So if you say malignant phylloides now with lymph node, axillary lymph node involvement, okay, acceptable siya, na? I-justify mo lang, na? Okay. So you have to change your breast cancer into a more specific type, no? So these are the usual breast invasive carcinoma, di ba? Okay. So yung secondary diagnosis mo is phylloides, malignant phylloides tumor, okay? Okay? Acceptable yan. Basta i-justify mo lang yon, ha? Okay? Kahit na yung pinaka-rare. Basta, okay. What about TB? Sige, para tumay. TB. TB is still present in this world, in this country, pero it's not common. No? So, can you have nipple inversion of TB? Sa TB? Medyo malayo ba yung mas nipple? Malapit lang, di ba?
3 cm from the nipple areolar complex, sir.
What? 3 cm? Medyo. Okay. Based on your drawing, malayo yata yung mass ninyo, no? based on your drawing, 3 cm from the nipple areola, pagkatapos may nipple retraction. Anyway, TB can cause with inflammation changes. It can cause yung mga cold TB, cold TB, walang hindi hot TB. Hot TB means there's obvious signs of inflammations, no? So you can have nipple retraction, inversion, no, by the TB, and also you can have lymph nodes, tama? Okay. So just try your best to come out with a secondary diagnosis, but you must have some logical basis. At least may konting malapit sa tamang sagot, no? Okay? So pattern of a particular disease that is not breast cancer for your secondary, no? Okay. We know in the end, parang you just put it at the back of your mind. Because an assumption there is we can never be 100% sure of anything. So you must have a backup, okay? And then that will also help you in your next step in your management, okay? So before we leave that, kasi I saw that yung mga wag na yung input yung I know theoretical lang yan eh. Yung mga in practice I don't input the family history, okay? Pag may obvious pattern ka na for breast cancer, wag mo nang input yung yung family history o kaya yung parity, yung minarch, theoretical lang yan eh. We don't usually apply it in practice, okay? For the discussion, yes, pero pagdating, kaya nga there's a disparity between clinical practice and then classroom discussions eh. Okay. So I don't, kasi kung wala siyang history of breast cancer in the family, breast cancer pa rin ang mo. Tama? Ang diagnosis mo. And then kung he's not in the yung late parity, kung tama-tama lang sa parity hindi mo rin i-negate yung breast cancer, di ba? Okay. So rely on the pattern recognition. Put aside yung don't waste your time with those. Okay. So when to use the family history?
If we're suspecting like a breast cancer mutation in the patient, sir. Like for this case, probably if early onset, sir.
Yeah, when do you input the family history of breast cancer into your diagnostic suspicion? Pag may obvious ka ng breast cancer pattern for breast cancer, don't waste your time with the family history anymore, di ba? Pero may mga sitwasyon na doubtful ka, di ba? Example, 4 centimeter solid, hard, movable mass, and then no nipple inversion, no lymph nodes. Okay? So yun ang scenario with a family history. Pwede mong i-input na yun, di ba? Okay. Pero the family history must be maternal or sisters, di ba? Huwag yung mga auntie, hindi nakasama yung mga auntie. Okay? Okay. So i-contrast mo lang, this patient, 39 years old, presenting with a breast mass 4 centimeter, solid, movable, sabihin natin no nipple inversion, okay? No lymph nodes. Scenario 1 is positive family history. Second one is negative family history. Mas mataas ang suspicion mo, probably a little higher for a patient with family history.
Yes.
Okay? Compared to, pero it's not very high, baka benign pa rin, di ba? Kasi no signs, if you use the pattern, benign siya eh, di ba? Wala siyang signs of malignancy, Saka yung nasa age group siya, nasa borderline siya, 39, Okay. Okay. Mahirap din gamitin yung age eh, Kasi dati during our time, we said that 40 and above. When you have 40 and above, we suspect breast cancer, ngayon, mga breast cancer ngayon, mas bata na eh, Mga 39, 35, ganun na, So the only time that I can use the age, baka 20, yung extreme na lang, 20, 60, 50, gano'n, na? Okay. Pag nasa borderline, 39, 40, 45, gano'n, you just have to base it on the pattern, na? Okay. Okay. Any question on that pattern, on diagnostic process? May strong disagreement? Wala. Will it make your diagnostic process simpler?
Yes, sir.
Yes, sir.
In 2 minutes, makukuha na niyo yung diagnosis. If you use my, ano. Okay. So wala tayong ultrasound, wala tayong ano. Suppose, okay, just to make things more interesting. Wala tayong ultrasound, mammo, wala tayong core needle biopsy pa. Okay, just a patient presenting with that picture. 39 years old, na mayroong 4 centimeter mass, movable, solid, lymph nodes. Okay, so your primary diagnosis, may nipple inversion, no? May nipple inversion and then lymph nodes. So your primary diagnosis is primary breast cancer. Okay, number 2 is sabihin natin TB. Let's stick to TB muna. Okay. So what will be your degree of certainty for you to be able to answer yung, do you need paraclinical diagnostic procedure? So what I'm trying to teach you is that you need to quantitate your degree of certainty in your primary and your secondary. Now, para you can proceed. Kasi ang next question is, after your diagnosis, you ask the question, do I need a paraclinical diagnostic procedure or not? Diba? As I said, as a rule, if you're quite sure, you don't need it anymore. Okay? Parang yung mga epidermal cyst nakita mo sa kamay, di ba? Quite sure ka na, huwag mo nang ibabiopsy, no? I-treat mo na, di ba? You can tell the patient 99% epidermal cyst, 99% is lipoma, no? So you just have to, you can proceed to the excision, huwag mo nang i-ultrasound o ano, no? Okay. So ganon. So you have the pattern for breast cancer, pero yung age group medyo duda, di ba? Okay, nasa borderline, di ba? Okay. So, and then yung TB, okay, itong 70-30 okay sa akin ngayon, no? Because you use fibroadenoma, no? But suppose it's TB. $10 lower, di ba? Tama? 10 or even 5% if you know the statistics, the prevalence, hindi, okay. Okay. May nagtanong sa akin yung ballpark, ganun. Okay. So, as a physician, you just use the process, no? And then come out with the data as best as you can, based on your experience, based on what you heard, no? Okay? Based on what you learned, no? Okay lang yung kamali ka, na basta meron kang, you tried your best, no? So, then after that, you will be learning from it, di ba? Kung let's say it turned out to be TB, TB nga ito, no? Lumabas, no? Okay. Or it turned out to be really breast cancer, you can say that talagang bihira yung TB, no? So later on, you can change your degree of certainty as when you meet another patient with a similar situation, no? Okay. So that's how I learned also, no? So over the years, nagbabago yung aking degree of certainty, no? When I see patients, no? Okay. So the degree of certainty, mahirap kunin sa libro yon, no? I've been looking for such statistics, wala. Such figures, wala, no? So in the end, it's still your yung tinatawag na based on your experience, your subjective, based on what you think, no? Okay. Okay. Then, papalitan mo lang as you go along. Kung mali ka, kung tama ka, gano'n, papalitan mo na lang, no? Okay. But you have to use it, no? kung let's say you're not a specialist like me for breast, okay lang, I can accept it. No, I won't criticize you for that. But as long as you use the process, okay. So at my level, I'm not quite certain 70-30, okay lang yan. But next time when you have another patient like this, probably you put that at 90 and then 10. Napapalitan mo na yon, no? Okay. So sabihin natin TB, kung TB siya, let's say 10%, then 90% dun sa sa breast cancer, na? Okay. So the treatment will be, so right away, yung sa treatment on this table, on this row, on this column na treatment modality, you can put there the usual treatment for such a condition, okay? Okay, for fibroadenoma, pwedeng observe, monitor, or surgical excision. Tama, no? Okay. Now, for breast cancer, you can also put the mga the options, pero if you know that most likely the patient will undergo surgery, no? Then you just put it there. The treatment will be surgical, no? Ganon, no? Okay. Pero kung di ka pa rin sigurado, just put them all the options, mamaya mo nang i-discuss with the patients, na? Okay? So basically, kung okay, TB versus breast cancer, anong treatment for TB?
Anti-TB meds, sir.
HRZE po.
HRZE therapy.
Okay? And then, or pwede ding excision, di ba? Okay? Kasi may nipple, di ba? Nipple inversion, gano'n, no? So those are the options. And then, sa breast first diagnosis mo, we all know that surgery will be the primary treatment for that, no? At the T2, stage 2. And then the other treatment that will come in will be mga adjuvant chemotherapy, radiotherapy, etc. No? Okay? So, kahit na nasa 90, I use 90 as a cutoff for degree of certainty. No? Okay, if it's 90 and above, it's quite certain ka na. As a rule, you don't need further diagnostic procedure. That's the rule. No? If it's less than 90, not certain. Okay? So you say sa atin, 90 saka 10 for TB. Di ba? Okay? But the treatment will be surgical. Possible surgical. And then for TB, you can justify your reason for doing a diagnostic test, because if it's TB, you have to give your anti-tuberculosis regimen, which is expensive, which is very toxic, di ba? So you want to make sure that it's really not TB, di ba? Okay, or it's really TB, no? So at 90-10, you're still justified to do a diagnostic procedure, okay? All the more if you put your quantification at 80-20, you have to go for a diagnostic procedure. Di ba? Okay. Kahit na 95 siya, there's a first breast cancer and 5% for the TB, okay, you can justify you're doing your diagnostic procedure. If you think that the patient needs will be needing complicated treatment, no? Okay, you want to bring it up to 99, ganon. Okay, you can justify it that way. So ikaw mag-justify, na? Okay. So nobody can dictate that for you, okay? Okay. So in this particular patient, if you need a diagnostic procedure, what diagnostic procedure would you do? Sabihin natin, wala pa siyang ultrasound, mamo, kasi nagawa na, no? So can you flash yung table on the diagnostic procedure? Yeah. On the first column, give me a rundown of options. Sige, Ryan? Ano yung mga options? Option naman. Options lang. Then, i-compare natin.
Sorry, sir. For the first.
Yeah, first column. First column is you list down the options, di ba?
Yes, sir.
Sige, ano yung options 1?
Core needle biopsy po.
Core needle, option 2,
Fine needle aspiration biopsy po.
3,
Excisional biopsy, sir.
4.
Yun lang po yung nakalist.
Hindi, yung sinabi ko, assuming wala ka pang ultrasound, wala kang mammo in this particular patient. Gagawin mo? Sasama mo?
Yes, sir.
Okay. So isama natin, di ba? Ultrasound and mammo.
Yes, sir.
Okay.
Opo.
So let's stick, there are more, ha? Eventually there will be more. Maraming nagma-market ng MRI, di ba? So eventually magiging popular yung MRI, isasama natin yung MRI ngayon, di ba? So it all depends. Kaya wala katapusan ng medicine if you don't use this process, di ba? Okay. One day may lalabas ng may nag-market that this is the trend, this is, lalabas yan. Ngayon very popular ng MRI. Okay. So baka mawala na yung ultrasound mammo. MRI na diretso, di ba? So you must know the process, no? So you compare the different options, no? In terms of benefit, that's number one. When you say benefit, which one will give you the best information that will firm up your diagnostic certainty? From, sabihin natin, 70, kanina 70 to 99%, gano'n, as high, or even kahit na 95 lang, pero ang target mo is 99%, di ba? Okay? So, and which one so kung meron kang data, you use it, no? Ang suggestion ko, don't use the sensitivity specificity. Very complicated yun. I don't know how you're gonna apply it. Just use it in, saka eventually when you present this table of information, you present it to the patient, no? Okay? You have to tell the patient, hindi nila maintindihan sensitivity specificity of the test, di ba? Okay. So you can say that the best yield here will be, which one? Among the 5.
Core needles are the best yield po for
That
diagnosis.
excision.
Excision.
Yeah,
Biopsy, sir.
Theoretically,
excision, sir.
di ba?
Theoretically,
Excision, you
sir.
remove the entire mass na, di ba? May histopath na, di ba? Okay.
Yes, sir.
Okay. So just for comparison, sabihin mo, let's put 5 plus 5. Okay? Kasi 5 sila, di ba? Okay.
Yes, sir.
And then, which one will be your second best?
Core needle,
Core.
sir.
Oh.
Yeah.
Third.
Third is fine needle, sir.
Okay. Okay. So what weight do you put on the ultrasound and mammo now?
Sir, I think my fourth po is ultrasonography, and then my last po is mammogram.
Last one.
Plus
Mammo.
one for mammo.
Okay. Do you all agree? Plus 5, plus 4,
sir.
plus 3. Agree kayo lahat?
Yes po.
Okay. So you can analyze it this way, or to reinforce that, bakit sinabi niyo yung excision, yung tatlong biopsy procedure na matataas ang weight niya, di ba? Okay, compared to ultrasound and mammo, na? You can say that these 3 are the most direct way of getting the information because it's sampling of the tissue. Whereas ultrasound and mammo are just shadows, imaging procedures. Di ba? Okay, you tell the patient that way. Naintindihan nila. Okay? Okay. So based on this, just yung 5 mo nang ipasok mo, actually pwede mo, you can simplify it mo na, sabi mo, biopsy, ilamp mo na under biopsy yung isa, yung tatlo, biopsy versus ultrasound and mammo. These are the 3 most common procedures that the patients usually are aware of, ngayon, okay? So, biopsy, mammo, okay. So, okay, lagyan natin muna sa biopsy, ultrasound, and mammo. So if you were the patient who saw this, if you were the physicians who saw this patient for the first time 1 year ago, or 2 months ago sa BCC, anong gagawin mo? Wala pang ultrasound, mamo. Minsan yung pasyente will say, pwede nang i-biopsy ho, kung pwede. Can you do the biopsy without the mammo, without the ultrasound?
With a breast mass,
I-
sir.
With a breast mass, ito, 4cm mass.
Yeah, I'll proceed with biopsy, sir. For
Okay,
me.
so you can, tama?
Yes.
Okay. So ngayon kasi lahat ng almost all doctors, they must have a mammo ultrasound. Na? Okay. So you can proceed with your biopsy. Okay. Kasi 4
Yes, sir.
centimeter na di ba? Kapang-kapa na. Okay. So then, if the patient does not want a biopsy, anong gagawin mo?
Ultrasound po, sir.
Ultrasound.
Okay. So pumayag ka, di ba? Papayag ka, di ba? Basta i-advise mo lang, no? So ayaw niya kasi hindi pa siya handa, masakit, baka may bayad, no? Okay. So you go for ultrasound. Okay lang, no? Okay. So what will the ultrasound? Sige, nagpa-ultrasound siya ngayon. Okay. But before we leave this table, so under the R, under the BR, risk, under the risk, which one has the more risk?
Biopsy.
Biopsy, di ba? More invasive, di ba? Compared to
Yes, sir.
ultrasound. Ultrasound practically painless, wala, no? Yung mamo may radiation, di ba? May radiation yung mamo, di ba? So in terms of cost, which one's the most expensive dito?
Biopsy po, sir.
Yeah, biopsy, and then among the three would be excision, the most expensive.
Excision po.
Diba? Okay, because that needs to be done in the operating room setting usually, no? And then the core needle, then fine needle, pinaka-cheapest among
Yes, sir.
three. And then between ultrasound and mammo, which one is more expensive?
Mammogram.
Yeah, okay. Mammo, okay. Okay, so okay, in mga private centers, it will cost about 3,000. Yung sa ultrasound, usually mga 1,500. Okay, ganon. Okay, sa private setting. Hindi mo ma-apply ng PhilHealth ito. Ha? You cannot apply with PhilHealth here. No? So ganon, just be wary of the cost. No? Okay. And then, of course, availability. Okay, usually available sa city. Suppose kung walang available sa probinsya, no? Then, if nobody is doing fine needle, nobody's doing core needle, you might settle for the excision. Now, if you can do the excision, di ba? Ganun. So it depends on the situations. Na? Okay. Kaya itong table nito, yung sinasabi ko, advantage nito, kasi I have experience working in the doctors of the barrio also, di ba? Not really doctors of the barrio, but we have this rural stint now for 6 months in the far-flung area. Parang helpless ka di ba? Because you were taught that this should be done, this should be done. Wala ka ng second best, di ba? Okay. So may backup ka pa rin. May tinatawag second best that you can do as long as you can justify it based on the situations. No? Okay. Okay. So suppose a ultrasound was done, anong in-expect mo if this is breast cancer? Anong findings?
Solid.
There's solid mass, sir.
Solid muna, okay. Ito kung talagang solid siya, no? So confirm, ano pa?
Probably with calcifications.
Yung
Probably with calcifications po, sir. Solid mass with calcifications.
okay, calcification, ano pa?
Hypoechoic po, sir.
Hypoechoic.
And irregular margins.
Okay. Okay, dalawa na isagot mo eh. Okay, yung hypoechoic is it will probably point to a solid already. Na? Okay.
Okay, sir. Irregular margins, sir.
Okay, irregular margin. Okay, so
Yes, sir.
ill-defined margin. Na? So yan yung isang clue. That's the radiologist, ultrasonographer usually use ill-defined margin as a basis to suspect cancer. Na? Okay. Yung calcification is not so much. Na? Okay. Ano pa?
I think sir, you can also see the abnormality of the lymph nodes then po. It will be reported also.
Okay, lymph nodes. Okay. 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 So yun, pag pina-ultrasound mo, lalabas nito, ill-defined, solid, ill-defined margin, okay, and then lymph nodes. Basically, kung nakita mo nitong tatlo, no, more or less, you can increase your degree of certainty na your clinical diagnosis of yung 70%, no, you can bring it up not to maka what 90%, no? If it's originally it's 90%, you can say it's 95% na, no? Okay? Okay? Kung mamon naman pinagawa, ano makikita mo that will tell you that it's cancer?
Microcalcification, sir, with fine branching architecture, sir.
Okay. Usually cluster, but it's present only 30% of cases, no? Even with the presence of a breast mass, no? Okay. Cluster of fine calcification is a signal for breast cancer on mammography. And then yung border niya, again, no? There's a density there represented by the mass, and then yung border niya, kung merong speculations, no? Okay. You know speculations, yung mga rugged border, okay? So if there's a speculations, that's a very reliable sign of cancer, no? Okay. Speculations, okay. So, baka may nakita yung nipple inversion, no? Kaya they put it a BI-RADS 5, no? Okay. So they saw some architectural changes, no, sa ultrasound as well as on mammography, okay? BI-RADS 5. Okay. So sabihin natin, ginawa na yung ultrasound. So your degree of certainty of breast cancer is already 95%, no? So the next thing that you might want to do, you can go for, you want to be quite certain because you plan to do a total mastectomy, so you need a biopsy. Okay, example lang ito, because there are other options. Sometimes you can go direct to the mastectomy if you're quite sure that this is malignancy already, no? As long as there's informed consent. Huh? There are some patients, I'll tell you, there are some patients who don't like a biopsy procedure because of the fear that it might spread. Okay, so take note of that. Have you heard of that, of those patients? Okay, kung ayaw nilang magpa-biopsy, as long as you are clinically, you're quite sure it's cancer, no? Accept yung offer nila, okay? Kasi a lot of surgeons will suggest, ay, ayaw mo, wag, punta ka lang sa ibang doktor. Okay? Okay. Okay. So you can still do it, but as long as, again, there's something on writing, informed consent, that you advise biopsy, that she doesn't want it, okay lang. Na? Okay? Para to save your neck also. Kasi kung pag ginawa mo without biopsy, it turned out to be benign, tapos this patient will go during dissatisfied with your treatment, and he goes to another surgeon, no? The surgeons will criticize you for in front of her. Bakit isang surgeon di ginawa yung biopsy? Bakit kayo inoperahan? No? Okay. But if you have a paper that supports that may informed consent, ligtas ka na doon. Okay? Wala ka ng problema doon. No? So, importante yung informed consent. Ha? Okay, so between fine needle, usually it's either fine needle or cold needle. No? Last resort na lang yung excision biopsy. No? Okay, if you have to do it. No? Tama ito, no? Core needle, you have more information. Let's see, it can give you as high as 95% yield. Sa excision, mga 98 to 99. Fine needle, 90%, no? Which is good enough. Anything that is 90% or better is good enough, no? At least 90%, no? So ang limitation ng needle is that you don't have a tissue biopsy, no? But core needle, you have the tissue biopsy there, no? Okay, but it's more expensive, no? Okay, so you can do the fine needle biopsy first, Okay. Let me input this, ito, mga community issues yon dito. In my practice, 39 years old, who might undergo a major surgery, modified radical mastectomy, as planned, as seen in this patient. And then to save her the cost of the operation, I usually do a fine needle biopsy first to document the breast cancer. And then I ask her to go to DSWD to get a PWD right away. Now, okay, all cancer patients are now considered as PWD. Now, so that's one thing that I do to help patients. Now, minimize their expense. Now, so fine needle first, and then with documentation of cancer, I give them a certificate. They go to DSWD, they get a PWD, patient with disability, they have 20% discount from the hospital. Now, so when I operate on them, they have 20% discount. Okay. So malaki rin yun, ha? 20% discount. Na, okay. And then you can do the HER2, yung ER/PR later on naman pag tinanggal mo na, no? Okay. So even that will be covered by the PWD, 20% discount. Okay. Okay. So core needle showed invasive ductal carcinoma. Tama? Okay. So options for treatment now will be, so you spell out the goals, and then so yung sa options for treatment, my comment here is that you can tell the patient, okay, by the way, ito yung mga side issue naman to, yung mga pre-op workup ninyo, no? Okay. Is it really needed? You're exposed in an environment in which there are a lot of things being done that are not really necessary, diba? Okay. Does he has comorbidities aside from the breast cancer? Wala, di ba?
Wala, sir. Wala po.
Wala. So you don't need all these pre-op workups anymore. Ito yung mga clearance, di ba? Okay.
Yes, sir.
So this will turn out to be negative lahat yan, no? It's a waste of resources, if not money from the part of the pocket of the patients, but also the time, no? That the patient will have to wait for a long time for the clearance. Pabalik-balik lang yun, no? Okay. So diretso na, no? So when in the treatment, you just consider, is it single modality or multiple modality? No? Okay. Usually multiple modality. Okay. For breast cancer. Now, for the multiple modality, anong uunahin niyo? Okay. So you mentioned radiotherapy, chemotherapy, and then hormonal therapy. When you say non-operative, this is the single modality? Sino nag-present ito?
Yes po. Well, I looked at it, sir, as the possible adjuvant or add-on therapy, sir.
Add-on. Okay. Okay, this is how I usually advise my patient. No? I list down on the first column the options: surgery, radiotherapy, chemotherapy, hormonal therapy. That's number 4. Okay. And then others that I put their alternative medicine. Okay. Okay. So nowadays, I really have to put alternative medicine because a lot of patients are going to considering alternative medicine. No? So if you present mo na kagad, no? Give them the information. No? Okay. And then on the benefit side, right away you can say in terms of for this particular patient, you want to control, you want to remove, you want to resolve the breast mass, di ba? Okay. And then control the recurrence, the progression, etc. No? So with the if you compare the 5 options that I mentioned in the first column, you can say unahin mo na kagad. Benefits sa alternative medicine, sabi mo, plus ano lang yan, 1% lang yan. Na, unahin mo na sila. Na? Okay. Okay. And then you go to the next one, surgery. Now, if you think surgery can be done here, okay. Kasi if this is stage 3, you'll tell them honestly, baka hindi kaya ng surgery dito. But you have to go to chemotherapy first. Na? Ganon. Na? But in this particular case, with the patient in mind, stage 2, let me say, now, so when we do surgery, 98 to 90% na matatanggal na kagad yan in one sitting. Na? Okay. And then for the radiotherapy, if you have to do it as the primary treatment, if you put the radiotherapy, probably 70% mawala. But you still need to do surgery afterwards. Na? Okay. Chemotherapy, ganun din. Na? So you give chemotherapy, yung chemotherapy, the chemotherapy cannot stand alone. Na? Okay, as a treatment. Na? So, but if you give chemotherapy in those who don't want other forms of treatment, sabihin mo lang, mga probably 70 to 80% then, compared to the 98% of surgery. No? Okay. Hormonal therapy, based on ballpark rin yun, no? Mga 30%. No? Okay. Effective din siya, pero 30% lang. That's why during the pandemic, hindi makakalabas for operation, we give tamoxifen, no? Just to control the cancer first before na mag-subside yung pandemic, di ba? Okay. So ganon, you just tell them in terms of benefit what is in terms of removal or resolution of the mass, which one has the most benefit. Then in terms of risk, just tell them surgery entails, ito nga, may sinabi ka, no? Hormonal, may mga flashes, no? Mga ganon, no? And then surgery, complications of anesthesia, operations, okay? And then you lose your breast if it's a total mastectomy, ganon. So the rest will be the same, ha? Yung sa table ninyo, no? Okay. So in this particular patient, what was done was a modified radical mastectomy. Tama?
Yes, sir.
Ilan ang lymph nodes niya?
During OR, sir, 1 lang yung na-evaluate. But yung sa histopath, sir, nag 5 out of 16 po siya, sir. Positive.
Where did you get that information, 1 positive?
Intraoperatively, sir, we were able to palpate po 1 enlarged level 1 axillary lymph node, sir.
Okay, so yung surgeon. So the
Yes, sir.
surgeons put down the note 1.
Yes, sir.
Okay. So okay. Small discussion here. Which one do you rely? The operative records or the histopath records?
Histopath po.
Okay. Usually histopath ang final. Kasi na? Pero the surgeon who operated on this patient should be the one to check the accuracy of the histopath report. Na? Okay. Kadalasan hindi nangyayari din yon, na? Okay. Lalo na sa training hospital. After the surgeons operate, usually hindi nakikita rin histopath, and then somebody in the follow-up, usually another resident will be the one looking at the patient. Tama? Okay. Walang continuity of care. No? Okay. So, usually, the surgeon should be the one looking at the accuracy of the report. Kung may mali, i-correct niya. No? Okay. Okay. Pero kung 1 versus 5, mas i-accept natin yung pathologist report kasi microscopic ito. No? So, even the sizes will vary, di ba? Anong nakalagay sa size sa surgical records?
4 by 5 cm.
Dito nakalagay 3.2. So anong susundin natin? Okay.
Surgical.
Okay. Ito lang, just one comment on that. You must be able to know how to interpret all these reports. No? Okay. And then the best will be the surgeons doing the operation, doing the report. Kadalasan dinedelegate na mga consultants, yung mga sa mga residente, no? Without checking the accuracy of the report, no? Yan ang problema, no? Okay. So with nodes positive, usually that's a sign of spread, di ba? Okay. So do you need a systemic treatment now?
Yes, sir.
Yes, sir.
Okay. So anong systemic treatment ang gagamitin natin?
Hormonal therapy, sir. For this
Chemo
patient.
also pwede, sir.
Considering that he has ERPR, di ba? Positive.
Yes, sir.
HER2 negative. Okay. So ano yung options mo? Options 1, hormonal. Option 2, chemo. Okay. Do we include radiotherapy? Sige, the question is, what are the additional treatment?
Yes.
Neoadjuvant. Neoadjuvant means after the operation. Okay. What are the other treatment that you can do that you would recommend to this patient after the operation? So if you ask that question, you have 3 options, no? Hormonal, chemotherapy, and RT. Diba? Okay. But if the question is, what are the systemic treatment that you can do for this patient? So we're left with hormonal, chemotherapy, and sama mo na yung alternative medicine again. Okay? Maraming nag-alternative medicine dyan. Okay? So you just have to compare, no? And justify it, no? So anong comparison between yung alternative, tell them 1% na rin, ha? Okay. Then, but comparing the hormonal and the chemotherapy, may data ba tayo dyan? Will it be sufficient just to give hormonal in the presence of 5 nodes?
I don't have full data po right now, but I agree, sir, na I think, according to my readings, mas effective po yung chemo compared to, mas effective po yung chemotherapy compared to hormonal therapy.
Okay.
Sir, parang I read the CPG po, and then sabi nila for locally advanced breast cancer with lymph nodes, the first line po is hormonal therapy with tamoxifen.
First line, advanced.
Yes.
After surgery ito?
After surgery po.
Hindi chemo?
One recommendation ata, sir, from NCCN would be adjuvant chemo followed by endocrine therapy, sir.
Yeah. Tama na ba sa yung graph?
Sir, CPG po. Wait lang po, sir. I can send.
Maraming information. Kung minsan hindi natin alam which one to follow. So the decision kung minsan will be influenced by the number of nodes also. No? Okay. Kung isa lang versus 5 or 4, no? Okay. So usually the assumption is that you want a stronger medications, you give chemotherapy, di ba? Kung isa lang, kung ayaw ng pasyente ng chemo, no? Then you can opt for hormonal muna, no? Hormonal therapy, no? So
sorry po. Locally advanced recurrent breast cancer, first line is tamoxifen po.
Locally recurrence. Recurrence.
Yes,
Recurrence na ito. Okay.
Yes,
yung
sir.
neoadjuvant, wala.
I wasn't able to read, pero I will agree po with my co-interns po.
Yeah. Sige. So most likely they would be the trend right now is chemotherapy, but and the states are coming out with some targeted therapy already, doing away with the chemotherapy. Yan sinasabi ko, you have to know to use the process. No? Over time, may mga bagong lumalabas. If you just, follow the trend, you have to keep up with the trend. Mahala na kayo, di ba? Pero if you use the process, no, you might be able to choose which one's the best for your patient. No? Okay. So, nagulat nga ako ng isang pasyente last few months ago in the US, Filipina, no? Nodes negative, nodes negative, but they're giving them a targeted therapy na. They don't give chemotherapy. No? Diretso na. And mahal-mahal yung targeted therapy. No? The new ones. No? So for now, so the principle to follow is that lymph nodes still the best. The presence or absence of lymph nodes still the best predictor of recurrence. No? Okay. And then the number of lymph nodes is also a good predictor. No? Usually they use the 4. Okay. 1 less than 4, more than 4. No? Okay. And then at the moment, the chemotherapy is still stronger than hormonal. No? Hormonal will be used after the chemotherapy. No? Okay. Okay. And then when you choose the chemotherapeutic regimen, again, the medical oncologist or the physician administering the chemotherapy should also again use the BRCA. No? A lot of times they just follow the trend. Ano yung pinaka-popular? Okay, ang pinaka-popular ngayon is docetaxel and adriamycin. Ganon? No? But probably 10 years from now, baka mag-iiba na naman yan. Di ba? Okay. And then the old ones, CMF. You've heard about CMF? Has anybody heard about CMF regimen? That's the original regimen. Cyclophosphamide, methotrexate, 5-FU. Okay. Now, for those who cannot afford the docetaxel, now you can opt for the CMF. No? Okay. But for the physicians who are close to the old ones, and then basta nung modern, gagawin niya na gagawin, no? Kahit nga hindi kaya ng pasyente, no? Okay. So, kung hindi kaya ng pasyente, aayaw na sila, di ba? So, but if you can offer a cheaper regimen, which might be 90% effective, or kahit na, let's say, 95% effective ang modern adriamycin, paclitaxel. Paclitaxel, kung yung 90% effective na CMF, pwede na yun, di ba? Okay. Try it out first, then kung mag-respond, well and good. Kung hindi, then you can shift to the other stronger regimen. No? Okay. So that's the principles to follow, no? When you treat patients. No? Okay, when you go to tamoxifen, yung hormonal, iba-iba rin yun, di ba? So first choice, yung isang option is tamoxifen. Number 2 is letrozole. Number 3 is anastrozole and others. Diba? Again, you compare the benefit. Which one will have the best benefit for avoiding local recurrence? No? Which have data on benefit on local recurrence and overall survival, and then compare the risk, no, of the medicines. So ano yung may high incidence of fracture?
Fracture, sir, sa tamoxifen po.
Hormonal? Sa hormonal?
Hormonal.
Tamoxifen?
Aromatase inhibitor, sir.
Letrozole, di ba?
Yes, sir. Letrozole.
Okay.
Tama ba? Letrozole? Anton?
I think, sir, aromatase inhibitors like letrozole, sir.
Yeah, mas mataas ang incidence ng ano, no?
Osteoporosis and related fractures, sir. Fragility.
Okay. So yun ang ano. Just take note of all those complications, but some would prefer it because of the mas effective daw siya, but they want to just to be vigilant on the osteoporosis and the fracture. No? Okay. But in general, you can try out tamoxifen first. No? Okay. Okay. So after that, we go for I think the health advice to the patients is well discussed already by Raf. No? Okay. So any questions? Everybody has spoken? Ryan, any questions? Any comment?
No questions from me, sir. I appreciated po yung the whole process that we went through today. Usually kasi in our other SGDs, we don't focus on the process. We focus yung mga theoreticals with the disease. But this one is this is one of the more unique SGDs I've been in, sir. Honestly. Thank you, sir.
Thank you. Okay. What do I say? Kasi number one, you're now interns, di ba? Interns kayo. Pero even sa clerkship, meron sa curriculum, sa learning objectives ninyo, SGD, usually it goes for, it's promoting efficiency na di ba? Efficiency in patient management, no? Okay. So if you go by the old style, hindi siya efficient pa rin di ba? Okay, the conventional style. And what I'm teaching you is actually what we do in practice. No, they don't. What the doctors do this in practice. They don't just jot it down kung yung process how to do it. No? But ginagawa nila yon. No? They don't jot down how certain am I with this one. Pero deep inside their mind, oh, I'm quite certain that this is one. This is the one. This one. Di ba? Okay, yeah, they make decision based on their certainty of diagnosis also, tama? Okay, they don't quantitate it lang, no? Okay, and then they don't usually advise the patient, yan ang problema. Okay, usually they don't usually advise the patient, tell the patients everything, they just put down some notes, ito nang gawin mo, ito nang inumin mo, no? Yan. No? Okay, and then the other one is, okay, with this advice, with this explanation, you get a lot of patients who will like you, who will appreciate you, and then also it will save you from trouble also, informed consent. No? Okay. It's a shared decision making. No? Okay. Thank you for your comment. Bea, anything?
Sir,
Questions?
medyo na-curious lang po ako on your take on antibiotics po. Kasi
Antibiotics?
yes, sir. Most especially post-op antibiotics po.
Okay, are you going to ask my take on antibiotics?
Yes, sir. If you parang recommend it or if you prescribe it to your patients po, yung post-op antibiotics.
Bakit mo tinanong yan?
Sir, kasi in one of our GS1 conferences last week, parang yun po yung isang topic na natanong dun sa isang residente na parang what antibiotics were the patient, like what did the patient take before and like did you prescribe antibiotics after? Parang yun po yung isang topic nung conversation.
Not
No.
journal club, conversation lang.
Sorry, sir, nung discussion. Sorry.
Discussions. Yeah, discussion. Tanong, consultants asking the residents.
Yes, sir.
So these are post-op patients, mastectomy.
Yes, sir. Yes, sir.
Okay, you ask my take. Okay, it's good you ask. Number one, I want to say that there are a lot of things, as I said earlier, there are a lot of things that we're doing that which are not necessary. Okay, so antibiotics for pre-op. Halos lahat binibigyan na pre-op 1 injection, di ba? 30 minutes, 1 hour before the cutting. Okay, tama?
Yes, sir.
Napansin niyo? Okay. So even with thyroid, which is a clean operation, okay? So mastectomy, binibigyan din. Ako, my style, I don't give pre-op chemotherapy. Okay. Number one, because again, it's a clean operation. Number two, based on my experience, 1 to 2% lang. Now, okay. So I've been doing operations for the past 40 years now without high incidence. And then there are studies that really show that there's no effect of chemotherapy. Okay. So we have a local studies done by Gemma Uy and Dr. Cabaluna. No? Okay. There's a local study that shows yung infection rate between no antibiotics and with antibiotics are the same. Yeah, ergo, there's no need, hindi siya effective, no? Okay. So, but a lot of things are still going on, doing all these things without analyzing, no? Okay. So I don't give. Post-op, I don't give also. Okay. So I just monitor the patient at the first sign of infection, then that's time I give. Okay. And I usually give the cloxacillin lang, pwede na. Okay. Okay. Anton, anything?
No.
Questions?
Sir, one question lang, sir, regarding BRCA testing. Because initially I was thinking whether it may benefit po for BRCA testing. I'm curious, sir, sa practice niyo, sir, when do you usually, or if you do, advise patients to get BRCA testing po?
I've not done it. No, I'll tell you honestly. But I think there might be situations in which you may have to do BRCA testing. So these are in patients who have very, very strong family history of breast cancer, okay, presence of cancer in the mother, sisters, no, okay. And then number two, the patients really wants it, no, wants the BRCA testing. Sa akin, even with the family history, they always ask me, do we need mammography every year, ganun, to monitor? Okay, to that question, I usually answer, even with this family history, I don't say, meron kayong slides kanina doon, di ba? May slides kayo kanina doon, screening earlier at age 25, di ba? Okay, so I don't usually use mammography as a screening. I usually ask them to do breast self-examination na lang every month, no? Stick to that, no? Okay. So yun, no? Basta breast self-examination every month, and then kasi maraming false positive ang lalabas dun sa sa mammography, usually mammography tsaka sa ultrasound. And then that will create more alarm, anxiety on the part of the patient, no? So basta close monitoring lang, no? Okay. Kung na-catch
Thank
ng
you.
1 centimeter, less than 1 centimeter, the prognosis is still the same as kahit na less than 1 centimeter, no? Okay. Okay.
Thank you, sir.
Nelson Lim. Anything?
So for me, I
Question?
comment lang sir na I appreciated the emphasis po on educating the patient rather than just like telling them what to do, and yung other emphasis on the importance of like what you find during the surgery and not just always relying on what the test results that come out after po. Parang I like that part po of the emphasis na yun yung important always for our patients.
Okay, good. Basta, ano yan, full-time attention sa pasyente as the surgeon, as the physician, no? In all the details, no? The only time that you do away with the patient, pag di na bumalik sa yung pasyente, wala ka ng responsibility. Pero kung wabalik-balik pa siya, no? Make sure that you take care of the patient completely, no? Okay. Good. Okay. Reg? Anything, Reg?
Yes. I'm just curious po what your approach is naman for male breast cancer patients. If it's any different or yes, sir.
Para lang, surgery pa rin. Surgery ang unang as long as you can catch it early, no? Practically the same, no? Then hormonal therapy, no? Ganun, no? Depende sa ER, PR din, no? Okay.
Thank you, sir.
Okay, sino pang di nakasagot? O, Raf, ikaw na.
Yes, sir. Sir, I would like to say lang na I appreciate the SGD because it's very practical. Just like what Ryan said, it teaches us how to approach the patient. Kasi sir, I'm having a difficult time minsan sa patient's OPD. I take a lot of time, minutes, 30 minutes, 45 minutes, and I've heard from some of my relatives, sa tito ko, sometimes, sir, you open your clinic daw mga 5:30 and then per patient, mga minsan 30 minutes lang. So I appreciate this because you're teaching us the the thought process itself para mabilis yung analysis ng patient. And hopefully this will help us develop our clinical eye din po when the time comes.
Okay, sige. Thank you for those comments. Okay. So, so I hope you will somehow you will adapt what I'm teaching you now. Okay. But if you are still undergraduate, kumisan you just forced to follow your other professors, no? Para pumasa mo na. But after you pass, you can be on your own na. No? Okay. So if there are no more questions, let's turn off the stop sharing na. Okay. So let's have a group picture together.
Yes, sir. Bea. Bea can take also, sir.
Okay. There, 1, 2,
1, 2, 3.
1, 2. Okay. So I will put a link on my Olete now. You try to answer it now. Okay. You have heard about my Olete now? Not yet. Okay.
Not yet, sir.
Okay. Yeah, docs. Okay. The link is there on your chat box, but I'll give the link also to Nelson now. Okay. So try to answer that Olete. Olete
Okay, sir.
stands for Online Learning Cum Evaluation Test Exercise. This is just a mastery reinforcement of the patient management process. No? Okay. Very easy, pero mahaba lang. No? Paulit-ulit lang. No? Okay. So if you get a perfect score, I'll give you a certificate. No? Okay. Add on credentials. Okay. So may bonus points kayo pag perfect. Pag walang hindi na perfect, less ang bonus. Lesser. Yeah. Okay. So thank you. We'll see each other. No? So can you finish this by last day na ninyo today? Last day in surgery?
For GS1, the GS1 rotation, sir. Pero 1 month pa po.
1
After.
month pa kayo. Akala ko last day.
Yes.
Okay. Yeah. Sige. So when can we set the deadline for this? Up to tomorrow? Pwede?
Okay, sir.
After tomorrow, sir. Sige
After
po.
tomorrow. Ah, okay.
Yes, sir.
Sige. Bye-bye. Thank you also for
Thank you.
your attentions and also bye-bye.
Thank you,
Thank you,
Bye-bye.
sir.
Thank you, sir.
Sir.
Bye, sir.
Bye.